Some COVID-19 respiratory precautions. So just to go over something quickly, is COVID droplet or airborne? It's kind of everything, because in the healthcare we're going to do things that are going to aerosolize this. For instance, we're going to if we give nebulizers, or we put a patient on BiPAP or high flow, or give any kind of humidity, we have a potential to create an airborne threat to this virus. We're actually going to be able to aerosolize this in the healthcare environment. For the most part, though, it's contact. You touch it, you touch these viruses, put it in your face, and that's how you catch it. We have a lot of knowledge gaps. We learn something new every day. We're learning things now, how to treat COVID that we didn't know before. For instance, it doesn't act like ARDS. We're actually having patients that get intubated and have fairly compliant lungs. They're just not oxygenating, and they'll have a lot of secretions, but it's not acting the same way ARDS. So we're treating it kind of wrong at first, and maybe intubation early and often is not the key. Maybe some type of modality like oxygen or non-invasive might be the best thing to prevent causing damage, unnecessary damage to the lungs. Also, things like early proning, pre-intubation proning, things like that. We've got to think of different ways to treat this. Here's a diagram or a picture of the COVID virus and how small it is compared to the aerosol that we generate from things like a nebulizer. The virus is so tiny that it'll just hitch a ride and make this. They'll kind of get transmitted throughout. We create this delivery system for these viruses. We're going to try not to use nebulizers because that creates this extra risk. And high flow and BiPAP right now are starting to be, at first they weren't considered, now they're starting to be considered for use because we don't want to intubate everyone. So for this, we're going to use minimum of an N95. We have surgical masks that we may wear coming in or around the hospital, but if we're doing any kind of patient care, we need to mask up for airborne precautions. Capper or PAPR, and we're going to head-to-toe protection. We're going to put gloves. We're going to put a gown, booties, everything. Oxygen respiratory barriers. We want to make sure that we're masking up our patients, if especially if we're going to move them from point A to point B. But certainly, if they're going to have some kind of flow-generating device, like a nasal cannula, high-flow nasal cannula. So it's just an extra precaution we can give to our patients and to protect staff and anyone else. Inhalers versus nebulizers. We're going to see more MDIs. We're going to see more inhalers because the aerosol is kind of just a delivery system for these viruses. Now, we may have a supply shortage in supply chain. It's possible with everything going on. So here's a diagram of how to make your own MDI spacer. And I do a video of this if you want to watch it, but it's pretty simple. Aerosol mask with reservoir tubing, and then we're going to put the electrodes on the mask to tighten the holes. And then the MDI should fit snug. And make sure all the fittings are tight. We put the mask on, and we have kind of a good makeshift spacer there. Possible nebulizer variations, if we're going to use nebulized medications, is we have it's called the Aerogen, and the Aerogen people have come forward and said, hey, our nebulizer creates smaller particles, which it does a vibrating mesh, which makes kind of a vapor. Okay, it doesn't make this aerosol, and so we use it a lot for vented patients. BiPAP because it doesn't add to the flow of the machine. And so we'll use this as maybe an alternative for aerosol. They do say that we should use it in a closed system though. Nebulizer variations out there, like this one, it's called the RespirGuard nebulizer. And it has a one-way valve, it has a filter, so it's a little bit safer when you're doing that. We're absolutely going to avoid all aerosols and humidities for the COVID patients because really these just kind of transmit everything. It just kind of makes a COVID steam of the room. So we're going to avoid these at all costs. Humidifying and tracheostomy, though, we're going to have to do that. So We're going to make a closed system. So you'll see on the left we have our trach boat system. And so what we're going to do is we're going to make a closed inline suction system. It kind of looks like the same setup when on a ventilator. We'll just take the aerosol tubing, hook it up to our inline suction, and then we'll make an exhalation port, but we'll put a filter on the exhalation. And this we'll use this for our trach patients, cuff up. And as an alternative, we have an HME also for transport. BiPAP and high flow, when the COVID pandemic first started, they were saying absolutely do not use this, but it looks like we're learning new things, and maybe non-invasive ventilation and high flow are the way to go. But as always, we always make sure that we're not high in a negative pressure room with all the airborne precautions needed. When using a BiPAP, we can make it safer by putting in a filter. Okay, we'll put in a filter in line in front of the exhalation port. You can see from the diagram, the exhalation port is that little hole that I'm pointing to, and that's where the air comes out. So we need to just put something between the patient and that hole to filter it. You know, we use a HEPA filter. You can also use an HME. HMEs are not approved for use with NPPV in this way, but we could still use it. It's not going to hurt anything. Yeah. We're trying to protect the patients. Make sure it's just one of those HMEs that that also doubles as a bacteria viral filter. When we're intubating the patient, bagging is still not recommended because we don't want to make any excess droplets when we're intubating. But when we're bagging, we're going to add a filter. And some ambu bags already have a filter, but if they don't, you just put it in line there. And then for ventilators like the LTV, where it's a transport ventilator, these are widely used in the ER. The exhalation port is in the tubing, and it goes to ambient air. So we want to make sure that we have a HME HEPA filter in front of the Y there, so we're not exhaling that stuff. So if we go to the next page, you'll see the circuit and the exhalation port is pointing to that little red part. That's where we exhale. Our patient exhales their breath, and we want to make sure that we have a filter in between that and the patient. So we have the HME bacteria filter between that and the exhalation port. Here we have a couple pictures of some transport vents at LTV. We have an Oxylog, we have the Voltron, and we also have a pneumopack. And you'll see that the filter is placed proximal to the patient. And make sure that we have a filter in line when we're transporting any of these type of patients. If we have a ventilator, ICU ventilator, we're going to make sure that we trigger the standby option before we disconnect the vent. We want to try to avoid breaking the circuit with these type of patients, but there's sometimes we may need to. So just make sure that we're not spraying that stuff all over the room, and so we put it on standby. Intubation precautions, there's a lot of different types of things we're going to do. We're going to make sure that we wear cappers. We're going to make sure that we use as few staff as possible so we don't have extra people in the room. RT, MD, RN, pharmacists, all gowned up, wearing the same stuff. Use a video laryngoscope if possible, and then use a barrier if you can, if possible. I made a video on how to use a makeshift barrier out of a bag with a ambu bag, plastic bag, but it's any other barrier that you could use to drape over the patient, and it gives you this extra level of safety when you're intubating. And we're going to make sure that we do everything under the barrier, okay? And we're going to make sure that we get rid of our soiled PPE properly and just don't leave it around. And same thing with the contaminated instruments.